Conversations in Frailty, the podcast for Derbyshire clinicians.
Thanks for listening in again. Do spread the word and keep sending in your feedback. It's always lovely to hear from you listeners out there. So, welcome to a diabetes episode today. This time I found myself heading up to Chesterfield and being grateful for the beautiful Derbyshire scenery I get to enjoy when I'm roaming around making these podcasts. This one was a fantastic opportunity to talk in depth to one of our very experienced diabetes nurse specialists about what's important in the chronic management of diabetes in our frail elderly patients. Look out for a later episode where we'll go into tackling more acute scenarios in these patients. So listen on to hear about pragmatic glucose testing and HbA1c targets, together with some practical tips around drug choice in cognitive and renal impairment. Okay, so I'm delighted to welcome Beth Cooper today to talk to us about frailty and diabetes. So can you introduce yourself to the listeners, Beth?
Hi everybody, my name's Beth Cooper and I'm the lead diabetes specialist nurse for the community team in North Derbyshire. I've been doing this job about 10 years now. It's very diverse and there's every day is a learning day, they say. And just a bit quickly about myself, in my spare time I like rock climbing and kayaking.
Excellent. I see some people who like doing outdoor pursuits on these podcasts, so enjoying the group.
Diabetes is a motivator for getting active.
So that's true. I'm hoping that today you have got a wealth of knowledge and expertise, and speaking to the ACPs and ECPs and the doctors out there listening, that you'll be able to give us some really practical tips and things to look out for in our frail patients. I thought we wanted to start maybe just thinking a little bit about the different types of diabetes and why it's important we think about those when we're discussing frailty. So just fill us in a bit on that.
Yeah, so I guess it's about looking at the different priorities and how they change for people when they've become frail. Mm-hmm. And I just wanted to do a quick summary really and encourage people that when you are doing a review of someone with diabetes, that the first thing that you always think about is whether they have type 1 or type 2 diabetes. And why is that important? And predominantly, it's because if somebody has type 1 diabetes, we can never stop their insulin. Mm-hmm. They need their insulin in order to survive, and I know that's really obvious, but occasionally when there's ambiguity about their diagnosis on the journal of the system, insulin does get stopped incorrectly. Mm. And obviously if they have type 2 diabetes, it enables them to have more options in terms of deprescribing and what medications you can reduce, what changes that you can make.
So that is one big mistake never to make, stopping the insulin in a type 1 when they become quite frail.
And I would encourage people to seek further support if you're feeling nervous about you've got someone with type 1 and they're reaching end of life or they're frail and it feels a bit overwhelming. That's what we are here for in terms of giving guidance on that kind of thing. I guess the other thing I wanted to just quickly mention in terms of that aspect of frailties, they may have been managing independently with their diabetes, so they may have been doing everything for themselves and suddenly they've reached a point in life where they need further support. And that can be quite frustrating for the patients, particularly people who've had type 1 diabetes. They might not want further input, but again, if you've thought about the type of diabetes they've got, it helps you to understand what the priorities are. Mm-hmm. There's obviously the physiological changes, so there's the organ type stuff, but then also the cognitive ability. So if people have got short-term memory loss, that kind of thing, that can have quite a big impact on how they manage their diabetes themselves.
And when we're thinking about diabetes, sort of chronic management, we're often, one of the first things we tend to think about is glucose levels. So how would you give some guidance on how we should look at targets of the glucose, both on a sort of day-to-day basis and looking at their HbA1c?
So what's really tricky with diabetes is that throughout somebody's life, they've always been drilled, mostly led by QOF targets really, into what their HbA1c target needs to be. And we're often thinking about 48 millimoles and trying to drive down people's blood glucose levels as well. this becomes not a priority. The reason that those target levels exist generally is that we know that if people have high blood glucose levels, high HbA1c levels, then they're much more vulnerable to long-term complications. When you've got somebody who's frail, that is no longer their priority. We're looking at the longevity and the fact that they're maybe not even going to be alive in 10 years, but we want them to have the best quality of life for the next 10 years. So firstly, looking at blood glucose targets, if they're finger pricking or somebody else is finger pricking for them, what would we be asking for in that respect? Well, there's two things to think about really. If they are not on therapy that's going to cause hypoglycemia, it may be possible to stop blood glucose testing completely. If they are on a treatment that can cause hypoglycemia like glycoside or insulin, then we need to be checking their blood glucose levels. But what I would always say is ensure that there is something being done with those levels. So for example, if they're about to take insulin in the morning and in the afternoon, it would be totally appropriate for them to be testing at those times. And if they're only taking insulin once a day, it would be reasonable for them just to be checking once.
So can I just, so you're saying insulin and glycoside are the key ones. Are there any other drugs that we should worry about the hypo risk with?
No, not really. It's being mindful of when they have other oral medications added into the insulin and the glycoside, that will pull down their levels.
Right.
So always remembering things like SGLT2s or metformin, if they've been added in or if there's a regime change, then it needs to be thought about. But insulin and glycoside are predominantly the ones that you need to be considering.
Fine.
So just blood glucose levels wise, finger prick wise, I have a fairly broad parameter, and quite often for somebody who's elderly or infirm or frail, it will tend to be between 6 and 12 millimoles, roughly. That may change from one person to another, but that's a broad parameter. And I would also encourage, if someone's liable to eating sweet treats or that kind of thing, and they occasionally have high blood glucose levels, if they've got type 2 diabetes, and that's not likely to be a concern to us if it's a one-off. Looking at HbA1c targets, again, looking at different guidelines, there is quite a lot of variation in what's advised in terms of frailty, but I would always lean towards the more relaxed targets. So I would be thinking that an HbA1c level of 9% for somebody who's frail would be totally reasonable. And I'm more, rather than actually looking at the numbers, I am much more looking at whether they have symptoms. So you can sometimes find that somebody who has had really tight control throughout their life, and it relaxes, that they start to be symptomatic when they've got an HbA1c more like 8%, more like 64 millimoles. And in that situation, it might be that we feel we need to help them we need to treat their symptoms with some medication. But if somebody's got a higher HbA1c and they're not symptomatic in any way, then we would just leave it at that.
And in the frail elderly, what are the symptoms that you tend to, are there any symptoms that particularly seem to appear at that point?
I think sometimes people don't necessarily associate the symptoms with the diabetes, but I'm thinking about urinary tract infections, I'm thinking about thrush. Those are probably the two main ones, but also significantly in an elderly person or a frail person who isn't able to communicate their symptoms, I'm thinking about constipation caused by dehydration from having high blood glucose levels. That's something that we've encountered a bit more recently.
Right, okay. Because we see constipation all the time in the elderly, and that's a really useful one to think of. So,
I recently had a case of an elderly lady in a nursing home with dementia who wasn't able to explain her symptoms, and that had become chronic, but it hadn't been associated with the issue of her blood glucose levels. Once her blood glucose levels were controlled, everything settled down.
That's interesting. And then I thought we ought to mention blood pressure, because I think in diabetes we always tend to focus on what are we doing with the sugars. But certainly in the sort of, for younger patients, the long-term risk of complications is actually reduced more by blood pressure than blood glucose control, isn't it?
Absolutely. So, in fact we know that blood pressure is actually probably more important than HbA1c in terms of how we treat our patients with diabetes. But again, similarly to the glycemic targets, once somebody becomes frail and we're trying to make sure that they have good quality of life, it's different. So we're thinking about earlier in life, we're thinking we want a blood pressure of 140/80. It may be that an elderly person or a frail person has had their blood pressure driven down to meet the QOF targets, and that's absolutely what we should be doing in younger people. However, if it's about thinking about, are they having any problems with falls? Are they having any problems where they're feeling wobbly, dizzy? And focusing on that and thinking, do we actually need to prescribe some of their blood pressure agents to avoid the risk of them having a fall because we're pulling their blood pressure down
too much? Yeah. So they're at high falls risk, these people, aren't they? Because if they have a high PO, they may fall, and if we overdo the blood pressure control, they may fall. So,
and unfortunately, they're at high fracture risk and a high poor outcome risk if they end up in hospital with a fracture. So the more we can do to prevent that happening, the better.
Yeah. And so you just go back to the blood glucose checking. So you were saying check levels with glycoside and insulin, and was the guidance essentially use the frequency around the frequency of administration? Were there any other sort of tips
frequency
on that?
of administration, or if you're doing a specific review of a patient and you need to understand what the blood glucose profile is across a 24-hour period, then you might increase the frequency for maybe 3 days. But it does make your fingers sore pricking to check for blood glucose levels. And I think over the years people have come to me and said, I've been checking, but nobody's actually looking at the results. So, I mean, for glycoside, we do need to keep an eye on it, at least on initiation in the frail population. But if they're well established and we don't have any concerns around hypoglycemia, there is the possibility that we can manage them with HbA1c checks every few months to make sure that that isn't a concern for us, rather than having to prick their fingers.
Yeah. Make sure we're treating the patient, not the anxiety of the carers, for example.
Yeah.
Okay. And moving on now, thinking about medications, de-prescribing is a big topic in Frailty that I seem to come around to in most of my podcasts. In the type 2 diabetics you mentioned at the beginning, there's often a bit of scope for de-prescribing so that we don't overdo the tight control. Are there drugs that you would particularly look to first in what's the sort of order you'd be thinking about?
It's always a really tricky one, and I think often quite time consuming in people with type 2 diabetes, because I will find that people are on a whole cocktail of different medications. It's about understanding when were those initiated, why, and are they having any significant benefit. Pioglitazone, for example, it's not prescribed very often anymore, but we know that that's high risk in people with heart failure or at risk of fractures. So you wouldn't want this group of patients on that medication, and you would just stop it. SGLT2s, they are being prescribed much more frequently now, because we know that they have benefit to heart failure, we know they have benefit to renal, and they bring glycemia under control at times. However, we also know that if people could become unwell on an SGLT2 and it's not stopped, they're at higher risk of ketoacidosis and complications. So I think it's about understanding level of competence and whether or not they have the ability to do that and stop it if they're unwell. You would hope that perhaps in a care home environment that you would be able to give those instructions, but if someone's managing their medication themselves, you might feel it safer to take them off that medication.
Sure.
As an example, we met somebody this morning who's on chemotherapy, who happens to be on insulin and an SGLT2, which was started before his cancer diagnosis. And it was just felt that this is just too complicated, it's too big a risk to him because his health is quite up and down. So we've stopped the SGLT2 for now. And as a result, we're going to manage him with the insulin that he's already on. He's going to check his blood glucose levels and we're going to titrate it accordingly. In terms of things like gliptins, historically, I don't use them very much at all. They're generally fairly limited in their effectiveness, so I often look to de-prescribe those. There may be a small group of patients where they have had a beneficial effect to stop symptoms, so to be careful not to stop them then. and some medications like linagliptin, for example, is used because you can use it in any renal function.
Yeah.
So people tend to lean towards that. But again, it's about looking at it, actually has it had any benefit for why it was started, even though... and I guess the one last thing that I'm thinking about is insulin, and I would think that I would be fairly quick to reduce or stop insulin in people with type 2 diabetes if I feel that there's the potential to do that. But it's tricky because insulin's a fantastic medication when someone's got really poor renal function. So...
And switching to a longer acting sometimes?
Yeah, that's a good point, is that you can switch them to a different regime, a simpler regime. So when they've had maybe prandial insulin because they've needed when they've been eating more in younger life or when they were feeling more well, they might be able to put them on a long acting that doesn't need that strong action anymore, just to keep them safer.
Yeah, fine.
And I guess the other thing, going back to the when third parties need to come and help these people out, when you've got people that are moving towards needing help from community nurses, that can add an extra complexity, and often we're involved in trying to simplify regimes then and have to de-prescribe for that reason.
Yeah. It's just the practicalities, isn't it?
Yeah.
And you touched on renal function, so just remind those of us who don't prescribe these drugs as often, when we've got a lot of our frail patients, their chronic kidney disease is gradually deteriorating, which of the ones that you want to particularly think about?
So all of the medications need some consideration. I'll go through it a little bit one at a time, just probably the simplest way to do it. So gliclazide is a medication that some people feel like it needs stopping when people have impaired renal function. Gliclazide's renally metabolised, so it can stack a little bit if people have poor renal function.
Right.
However, it's much simpler than insulin. So what I would say to people is just be cautious about the dose. If you feel like it's a beneficial medication for that patient, try it, but have them monitoring. We have a 40 milligram dose, so they can start it on a very low dose and monitor them that way. But if someone, for example, is on gliclazide and they suddenly stop eating, obviously that's the medication that's going to need to be stopped, particularly if they've got poor renal function, because they're at risk of hypos as a result. Metformin's a brilliant drug. It's really effective, it's not too expensive, and it's very simple in the way that it works. However, we know that it can add complexity in frailty. The guidelines will advise stopping it when EGFR drops below 30, and that is generally what is done. You might find some diabetologists that are keeping it on because they feel that it's helping that patient, but they will only do that if the renal function is stable and not deteriorating. On that note, it's worth commenting that we have situations where we have patients admitted during frailty, and all of these things get stopped. And I don't always think we get communication comes back to primary care about why, how, whether we restart them. And I think, we can always support with that, but I think it's just remembering actually some of them will likely need restarting slowly and carefully. And if you ask the consultants about how and when, they will generally say recheck EGFR once they're home, in their home environment. And if it's stabilised back to how it was prior to the hospital admission, then you can restart things. SGLT2 wise, I'm encouraging clinicians to record why those SGLT2s were started in the first place, because now they're not always started for diabetes. It gets quite confusing. People might lean towards stopping it if EGFR is dropping, because we know that the way that it works, it's not going to work very well if EGFR is poor. But if it's been started for heart failure or renal function, needs to be continued. In terms of DPP4s or gliptins, I would always encourage people that if someone's got impaired renal function, lean towards linagliptin. Because quite a few of the other gliptins need titrating or changing the dose according to renal function, which requires someone to be reviewing, someone to actively change doses. That's not required for linagliptin, so if there's any worries about that's the most sensible choice, although it's a little bit more expensive, it keeps the patient safe. And then GLP-1s, These are the medications which suppress appetite and try and help your endogenous insulin work better. We are going to be seeing these more and more as time goes on. We've got Manjaro that's just come out last week in Derbyshire. And so I think we are going to see more and more of their use in the elderly, more frail population.
Mm-hmm.
So with that in mind, when somebody's starting to eat less and become more frail, it's appropriate for that medication to be stopped, because this medication is going to suppress their appetite and probably make them feel quite unwell, I would suggest, at that stage of life.
That's very helpful, because often other conditions, things like dementia, can affect appetite and eating behaviours, and actually being aware that that's a drug to think about deprescribing in that sort of situation then. Yeah,
it's interesting you should say that, because I guess on the flip side of deprescribing, it is being used in those patients, maybe with cognitive impairment, dementia, who we're anxious about starting insulin because we're worried they might not be safe, they might not eat consistently,
okay.
Whereas you can use a GLP-1 potentially to curb maybe their appetite for eating biscuits and cakes and things inappropriately.
Yes, you get the two extremes. Yes, you have the people with dementia who don't want to eat, and the people who seem to have no control on their sort of sweet tooth and that sort of things. Yeah.
And GLP-1s are generally licensed down to an EGFR of 15.
Okay.
So that in some ways is really helpful. But I think it's just a case of making sure that in that particular person it's regularly reviewed, so that if anything is changing in terms of their well-being and eating, it's not continued.
So I think that's all the key, the common drugs sort of covered there, isn't it? And we often, I think the one that springs to mind for me is we often start metformin and people come back with diarrhoea, and that's a common troublesome side effect. Are there any other side effects that become particularly more prominent in the frail elderly? Or
I think sometimes it's about them not coming forwards and telling us about the symptoms or side effects that they might experience. But I suppose with SGLT2s it's balanitis and thrush.
Yeah. Because of the sugar in the urine that they're peeing out, essentially.
Exactly.
Yeah.
And if they are having sweet treats or snacks, they're going to be more inclined to get that thrush. Yeah. And I think, although when it's mild, I would encourage just using something like 1% clotrimazole to treat and cut down on eating carbs.
Yeah.
It's always important to think, you know what, this is, even though it might be having a really positive effect on glycemia, this particular person is not tolerating it because of the significant side effects. And I must admit, it's probably only about 5% of patients, but there tends to be a group where they just seem to really get extreme side effects from SGLT2s of thrush or balanitis, and we just stop it in that situation.
Fantastic. You've covered all sorts of different sort of issues in the frail elderly. Any last one that you'd want to just get the listeners thinking about before we finish for today?
I guess just a quick touch on dexterity, because that's something which is often an issue in elderly people with potentially arthritis or neuropathy in their hands. I'd love to say there's loads of things available for those people, but unfortunately the drug companies are reducing what is available. We used to have an insulin pen called the Inalect till fairly recently. That's been discontinued now. So that had really easy to dial up, and it had buttons on it for if you were blind, but that is going to be discontinued. What I would say is, if you are planning or hoping to start somebody on a device, just let them try them.
Okay.
Because often it surprises me which one they find most easy to use. I'll think something's going to be very easy, and actually that's not the case.
They struggle. Okay.
Yeah, I let them just try out the devices and see which one suits them best. But it is difficult, and things like putting a needle on an insulin pen suddenly can become the difference between being able to have that therapy or not.
Yeah.
So it's just a reminder to think about that when you're considering which medication is going to be best for somebody. And I guess it could be a reason why, certainly for a period of time, you might lean towards gliclazide instead of insulin.
Yeah, just the practicalities of it.
Yeah.
No, that's a really good point. Fantastic. Well, there's lots more that we could talk about, because we haven't gone into hypo and hyperglycemia and sort of acutely ill, frail diabetics. So we'll come back to that on a future occasion.
Okay.
But thanks ever so much for that first
You're
part
welcome.
today.
Bye-bye.
Well, once again, lots to reflect on here. In terms of learning points, perhaps it's just worth reiterating the key safety tip at the start. So if we're deprescribing insulin in a frail elderly patient, always make sure it's not type 1 diabetes. And we're definitely seeing more of the SGLT2 inhibitors coming through. So there were a couple of helpful points around those to reflect on. One, that we should always stop them in acute illness, particularly here where the ketoacidosis is a risk. And secondly, that it's a drug to think about if we're seeing a recurrent case of thrush or balanitis, and whether it's appropriate to stop the SGLT2 inhibitor depending on what it's being prescribed for. And this episode also made me ponder on the often forgotten psychological impacts of increasing dependency in our frail cohort. I was thinking of those type 1 diabetics who've often managed their condition competently and independently for years. They must feel so disempowered by struggles with dexterity or memory and the inevitable need for support that comes with that. So I hope you've enjoyed this episode. I'll say bye for now and hope to have you back for my next discussion with Beth, where we deal with hypos, hypers and more. And as ever, please do remember that this is a discussion with one expert in the field. When making individual decisions about patients, always take local and national guidance into consideration and use your clinical judgment.
Conversations in Frailty. Thanks for listening.